Okay. So today I'll be talking on this topic, weaning and failure to wean, optimal roadmap to recovery. So this talk was given in South Zone, Calicut in 2015, October. So the topics that I would be covering is process of weaning, the methods of weaning, and different types of weaning and the studies done with regards to spontaneous breathing trial, TPs, and duration of the weaning and work of breathing, predictors of weaning failure, extubation to NIV, and weaning protocol summary and recommendations. So if you look at weaning, I think there are two major components of weaning. One is to look at readiness to wean. So that is the first step that we need to embark on. And the second one is actual process of weaning. So the first step, as you would try to ascertain readiness to wean, you need to look at objective criteria that patient is going to fulfill for the weaning to be initiated. And the actual process of weaning incorporates reduction of whatever support the patient is on. And so the reduction of full support. So basically, once patient is ready to be weaned, so you may negate the full support, which means you basically put them on spontaneous breathing trial. Or the other domain is to gradually reduce the support and take them off the ventilator. So these are the two ways that you would approach the weaning. One is gradual reduction, and the one is directly put them onto spontaneous breathing trial. And once they satisfy these two, then you would discontinue mechanical ventilation. And this whole weaning process is shown to significantly reduce morbidity, mortality, and reduce the cost, because the weaning trials is something that we need to initiate as soon as you believe that acute insult or acute disease condition is settled. That is when you should immediately start looking at putting them on weaning process. Otherwise, you would prolong their mechanical ventilation, and that is shown to significantly reduce your cost and obviously morbidity and mortality. So how do you choose a weaning method? So these are the three broad categories of weaning uh, methods. One is spontaneous breathing trial. The second one is slowly reducing the pressure support and then trying to taking them off the ventilator. And the third one is reducing ventilatory associated breaths. So the typically, so the weaning, the duration of weaning somewhere would fall between 30 minutes to 2 hours. So that is the initial trials that we give. So if you are using pressure support or gradual reduction in pressure support, so you would try to bring down the pressure support to 5 to 7 and try to ascertain if they are okay to be extubated, or you put them on a CPAP, or the Puritan Bennett ventilators have automatic tube compensations, which also could be utilized for the weaning to happen. So once they satisfy this criteria for 30 minutes to 2 hours, they are able to maintain their normal vital functions, normal heart rate, blood pressure, respiratory rates, and saturation. If they are maintaining at good physiological levels with this weaning sort of a trial, then obviously it is called successful, and then you would extubate them. So if they fail this whole process, then you would work them up for weaning failure. So that is when you have to take additional steps to determine additional steps that may be needed to wean them off ventilator. So what has been found is spontaneous breathing trial is found to be effective, efficient, simple, and safe. So this is found to be more practical, and there are multiple trials to compare spontaneous breathing trial with gradual reduction of pressure support or with reduction of ventilatory associated breaths, and see which one fares better with regards to weaning process. So if you look at the spontaneous breathing trial studies, so there are multiple studies. As you see, they're all old studies which have come started from 1995, and subsequently there have been multiple studies. So this was a Spanish study where they compared spontaneous breathing trial once a day with intermittent mechanical ventilation. Okay, and they found that the relative risk of successful weaning was much better. So the weaning happened much better when patient received spontaneous breathing trials once a day as opposed to intermittent mandatory ventilation. And they compared spontaneous breathing trial once a day with pressure support, where you gradually reduce the pressure support. And in fact, they found spontaneous breathing trials was much better in successful weaning. So it led to successful weaning much better, and that was statistically significant. And this one they compared once a day with intermittent spontaneous breathing trial, so there was no significance. So this was again another study from US. So in 300 patients where they compared between spontaneous breathing trial and the conventional weaning, they found the duration of mechanical ventilation was significantly less when patients were put on spontaneous breathing trial. And complication or risk factors like reintubation, trachea, and prolonged, all this was less when patients were put on a spontaneous breathing trials. And if you see, most importantly, the cost was significantly less when patients were put on spontaneous breathing trials. So basically from these they concluded there is absolutely no difference when you compare TPs in spontaneous breathing trial. So either you put them on TPs, pressure support of 5. So 5 to 7 of pressure support is consistent with almost TPs in all the trials. Okay, or CPAP where you don't give any pressure support, or with automatic tube compensations. All studies have shown all these have been shown to be equally effective and there is no difference. So either when you do spontaneous breathing trial, you can put them on TPs or put them on pressure support of 5 to 7, or CPAP where there is no pressure support with only PEEP, or automatic tube compensation. They found no difference. But what they suggested is when patients have ET tube of 7 or less, then the TP's maybe work of breathing was found to be little higher. So they suggested pressure support ventilation or automatic tube compensation may be better to compensate for the tube resistance. So that is what. So if the tube size is small, 7 or less, then the suggestion is to use pressure support or ATC and not only TPs or CPAP. So what about TPs trials? So we looked at the SBT trials. So the TPs, so this was the biggest study, Cochrane database in 2014. 935 patients. They compared spontaneous breathing trial with pressure support and spontaneous breathing trial with TPs. And they found there was absolutely no difference with regards to weaning or reintubation. And even hospital length of stay and ICU length of stay was no difference. So you can use spontaneous breathing trial with pressure support of 5 to 7 or with TPs. So either of them you could use, there was no difference. So this was a Canadian study. Again, they looked at spontaneous breathing trial with CPAP of 5 and TPs, reintubation, there was no difference. And this was a study from Switzerland where they looked at spontaneous breathing trial with ATC and TPs. Even there, weaning success, there was no difference between. So all these are, that's why when I say there's absolutely no difference between TPs, ATC, CPAP or pressure support of 5 to 7. Pressure support of 5 to 7 is considered as sort of a extubatable sort of parameters. And they looked at automatic tube compensation versus CPAP. This was an Israeli study. They found no difference in reintubation. They compared automatic tube compensation versus pressure support ventilation. There was no difference in reintubation. So, which again says ATC or pressure support or CPAP, you can use any of them. So, if you are using Puritan Bennett ventilators, there is a ATC involved. So, you could use that. So how about overcoming endotracheal tube resistance? So what they found is when you have a narrow ET tube, so there is increase in the resistance and there is increase in the work of breathing. So this was a study where it was in a small study of 22 patients where they found when patient is intubated for a little longer time of 4 days, the work of breathing was found to be much higher, and even post extubation there could be a risk of extubation failure. And work of breathing, they compared between these modes, TPs, pressure support and CPAP. There was no difference with regards to work of breathing. But in someone who is intubated for longer than 4 days, so there was a small increase in the work of breathing because of the length of intubation had a bearing on the work of breathing. So this was a study from French group. Again, they looked at work of breathing in patients who were intubated for 7 days, and they found the work of breathing was similar when they were on TPs and even after extubation. So although the previous study said that after 4 days the work of breathing would be little higher, so this study did not show increase in the work of breathing between TPs and post extubation. So this was another study where it was a small study by French group done in 31 patients who had failed extubation, and then they were subsequently weaned on pressure support, and 68% of them were successful. So again, this study sort of inclines on using pressure support ventilation because they had failed sort of a TP trial, but then they were slowly weaned off the pressure support. For 30 minutes they were maintained on 7 centimeters of pressure support, and then extubation was possible. So the weaning success was around 68%. So this study tends to lean on more towards using pressure support as a weaning mode. So what about duration of weaning trials? So when you say you need to wean patients and give the weaning trials, so what do we understand? What do you mean by spontaneous breathing trials? So the weaning trial is somewhere between 30 minutes to 2 hours. So it is recommended that 30 minutes generally would be sufficient to determine that if they would be ready for extubation. 30 minutes of spontaneous breathing trial. But if they fail 30 minutes, then obviously you need to go back on your ventilation, and then later on you may have to give a trial of 2 hours to determine if they are going to succeed with extubation. So if they fail 30 minutes, then the suggestion is that you need to put them on that weaning spontaneous breathing trial for 2 hours. Okay. But it is suggested if someone is ventilated for more than 10 days, you should give spontaneous breathing trial for more than or equal to 2 hours, because as the duration of ventilation increases, the propensity of them to fail extubation is much higher. That's why your spontaneous SBT trial should be for a longer period, for more than or equal to 2 hours. So these were the studies to compare between 30 minutes and 120 minutes, 2 hours and 30 minutes as a duration. So this was a study done in 526 patients. They compared SBT of 30 minutes versus 120 minutes. Weaning failure or re-intubations were similar. So this study showed no difference between 30 minutes and 120 minutes. So this was an Italian study in 75 patients who were COPD, mechanically ventilated for more than 15 days, and the median duration was 120 minutes to indicate that possibly they would fail or not. So they said 120 minutes, 2 hours as a trial would be a good duration to determine whether they are going to fail or succeed. So how about identifying weaning success? Obviously, you need to rely, in addition to all the weaning trial you give, you need to look at a lot of clinical parameters. So you wouldn't obviously put someone on a weaning trial if they are agitated or if they are very drowsy. So you wouldn't put someone on a breathing trial or SBT trial if someone is tachycardic or more than 20% of the baseline heart rate. So you wouldn't put someone on a weaning trial or SBT when the respiratory rate is more than 35, or when they have hypoxemia, or when they have acidosis, you wouldn't put them on a breathing trial. Or if someone has extremes of blood pressure, hypotension or very high blood pressure, so you wouldn't put them. So these are all some of the basic intuitive clinical variables which we follow. So obviously our understanding is most of the physiological variables should be in a normal sort of a range before you put someone on a SPT trial. So when do you decide someone to extubate? So once you know that someone is conscious, oriented, and all the physiological parameters are within normal range, then you would see whether he is fully conscious, whether he has a good cough, whether he is able to clear his secretions. I think these are the typical things we see day in and day out. Because even if they fulfill all criteria, and if someone is obtunded, you wouldn't extubate, or if it's an elderly patient with a stroke who may fulfill all these criteria, but if he has a very weak cough, you wouldn't extubate. Or if someone has a copious secretions, you wouldn't extubate. I think these are typical things we follow. So you need, or if the someone has severe neuromuscular weakness, then also you wouldn't extubate. So weaning failure. So obviously, when after you have succeeded in SBT trials, still they can fail when patient has anxiety, delirium, or if they are in volume overload. They may fulfill all that criteria on positive pressure ventilation, respiratory rate may be okay, and heart rate may be okay. But if they have a low cardiac output state, and so there can be a risk of them going to fluid overload once you take them off the pressure support. Or if they have severe metabolic, someone fulfills all criteria, but you have severe hypokalemia or hypo or hypernatremia, hypophosphatemia, all these could be the reasons that they could fail extubation, although your weaning trials may have been little successful. Or cardiac dysfunction. I think this is a typical thing we see in ICU. Although they may fulfill all those criteria which I showed in the previous slide, normal blood pressure, normal tension, normal heart rate, normal respiratory rate, but once you remove positive pressure ventilation in someone with a poor LB, or low cardiac output, we see often that they can fail extubation. So you need to have that in mind. Or someone who has a chronic respiratory failure, or COPD, or interstitial lung disease, or neuromuscular weakness. I think these are typical reasons why they could fail after you may have succeeded in your SBT trial. So this was another study from the French group where they looked at which one fared better when they failed initial SBT. So this was a study in 109 patients where they had failed initial spontaneous breathing trial, and then again they put them on a SBT with TPs after for 2 hours, and one group they put them on prayer support and another group they put on intermittent. If you see, the duration of weaning was significantly better when they put them on pressure support ventilation. So I think you saw two studies where they tend to lean towards pressure support ventilation as a means to hasten or to get successful with weaning process, because here the duration of weaning was much lesser when they put a PSV as opposed to again SBT with TP style or intermittent mandatory ventilation. So the conclusions from all the studies was intermittent mandatory ventilation is not recommended as a weaning, and spontaneous breathing trial, you could start off once a day for 30 minutes and see if they succeed, well and done, or 2 hours based on the duration of ventilation. If they succeed, that's well and good. If they fail, then it is good to switch on to pressure support ventilation, start slowly reducing the pressure support, and then wean. And whilst you are doing this, correct reversible cause and reassess for readiness to wean the next day. So SPT is fantastic as an outset. You give 30 minutes to 2 hours depending on the duration. But if they fail, it's better not give another SPT again. Better to switch to pressure support as we normally do. Reduce the pressure support slowly to 5 to 7 and then extubate. I think that would be the more logical way. The reason they suggest that is, see this graph typically shows once they fail extubation, there is severe diaphragmatic fatigue, and you see there is at least 48 to 72 hours that it takes for them to recover the diaphragmatic strength. So it takes a lot of time for the fatigue component. Here it shows at least 8 hours to come to some plateau phase. So you cannot subject them to another trial within that 8 hours. So it takes really little more than 8 hours to come back to the baseline. So once they fail, you probably have to rest them, and maybe more than after next day only that you would try to put them on SPT or pressure support ventilation. So how about the concept of extubation to NIV? Because if you have someone who's second day you try to put on pressure support, again you are struggling, then the concept of extubation to non-invasive positive pressure ventilation. So this was a Canadian study, one of the very big study, meta-analysis of 12 randomized controlled trials, 530 patients who had failed SBT. So who had failed initial SBT, they extubated to non-invasive positive pressure ventilation, and they found when compared to the group which was not extubated, mortality was significantly less, the VAP rates were significantly less, duration of mechanical ventilation was significantly less, and the need for trachea was significantly less when compared to the group which was not extubated to NIV. So which means if you are struggling for someone to succeed in spontaneous breathing trial or someone to wean on pressure support, the option is to extubate on NIV, which we commonly do because this study significantly shows it improves outcome. So conclusions is extubation to NIV should be considered in patients with COPD. Typically we do that, or patient who has no difficult airway, because if they have difficult airway then you are in a problem. So if there's a difficult airway, better is to go for a definitive procedure like tracheostomy, or someone who has no increase in secretion, because if they have a lot of secretions it's difficult to clear an NIV, and good mental status. So these are some of the clinical situations where you could extubate to NIV to get them to succeed with weaning. So what about weaning protocol? So the evidence-based strategy does suggest that weaning protocol should be in place to determine readiness to wean, and the weaning trial has to be a part of the protocol, and multiple studies have shown that protocols are beneficial in initiating the weaning, because typically intensivists cannot oversee weaning for every patient. So it should be sort of an automated thing which should happen from the bedside. And typically in the Western world, we all know that nurses initiate the weaning, or respiratory therapists. So doctor literally cannot be overseeing weaning of every patient. So there should be a protocol, and every nurse should be sensitized to the protocol, so that at any opportune time when patient is ready, they should be put on weaning protocol. And this was a study from UK where they have shown whether weaning protocol really helps. So this was a meta-analysis of 11 randomized controlled trials of 1971 patients, where they showed that having weaning protocol in place implemented in the unit significantly reduces the duration of mechanical ventilation by 25%. But this benefit did not apply in closed ICU. It applied only in open. What it means is open ICU, there is no decision maker. So which means the nurse initiated sort of a protocol implementation led to the success. But in closed ICU, because there's intensivist who is taking a call at every step, so this protocol did not make a difference. So that is how you would look at it. So what about automated weaning? So there are ventilators which have this automated weaning where pressure support is adjusted to the patient's respiratory rate, tidal volume and carbon dioxide. And once these are stable, automatically pressure support is reduced by the ventilator. So these are available in commercial ventilators. And this was again a study from Canadian group to show whether this automated weaning helps. So this was again a meta-analysis of 21 randomized controlled trials where they found with automated weaning, duration of mechanical ventilation came down by 10%, ICU length of stay reduced by 8%, mortality there was no difference, and benefit was seen only in medical cases, not in surgical cases, not in post-op patients, and there were no harmful effects. So which means to say, if you are using a ventilator where there is an automated weaning like adaptive support ventilation or any of those weaning modes that are there, you could utilize it because that does not need any human intervention to initiate weaning, and ventilator automatically senses your respiratory rate, tidal volume, carbon dioxide, and it starts reducing the pressure support. But the limitations of this study was it had heterogeneous group of patients, and we don't know whether it is applicable to pediatrics, or if CO2 is more than 60, then we do not know whether this automated weaning process would help. So my summary and recommendation is weaning is a reduction of support a patient is needing from the ventilator and to get him off the ventilatory effort. And the weaning typically comprises of spontaneous breathing trial. That's what we understand by weaning. And this SBT can be used with TPs or low level of pressure support, which is 5 to 7 of pressure support. Could be used with CPAP or automatic tube compensation. But this automatic tube compensation and CPAP is not should be used with caution, especially if you have a smaller ET. If you have dealing with a smaller ET size, its suggestion would be to use lower levels of pressure support. And once they are ready, so once a day SBT gets a grade 2B recommendation, and typically first SBT could be given for 30 minutes. If they succeed, you could extubate. But if patient is intubated for a longer time, it is suggested that you give a longer SBT trial of 2 hours. But in patients, as I said, if they are mechanically ventilated for more than 10 days, typically you should give for longer SBTs. Okay. Or if they fail initial SBT, the second SBT should be for a longer period, 2 hours, or you can think of pressure support weaning. If they tolerate, you extubate. If they fail, you put them back on ventilator and then again reassess for weaning maybe after 24 hours. So progressive reduction in pressure support ventilation is something that one could consider if they are failing the SBT on TPs. Intermittent mandatory ventilation alone is not recommended as a weaning protocol. And it is suggested that weaning protocol should be put in place, and it was found to be very useful in open ICUs or where there is no qualified intensivist. But in closed ICU, I don't think there may be a compelling reason to have a protocol. So, and these are the levels of recommendation. So grade 1B for open ICU, grade 2B. So level of it's a weaker recommendation for closed ICU. So, and to end my talk, I think we all need to understand the SBT trial or the weaning protocol is a structure indicator. So it is a quality indicator, and the benchmark is 55% of all your ventilated patients should be on some form of a weaning protocol at any point of time, and that is how you calculate. So 55% of your ventilated patients at any point of time should be given the weaning protocol or a weaning trial. So thank you very much.